Good afternoon, everybody. Dean, Acting Executive Director, Board of the Faculty of Nursing and Midwifery, Honorary Fellows, distinguished guests, ladies and gentlemen, it gives me great pleasure in welcoming you to this afternoon's Faculty of Nursing and Midwifery Royal College of Surgeons in Ireland Education Masterclass. Thank you all for coming to this event. The title of the Masterclass is Implementing Integrated Care, Leading System Change, Enhancing Patient Flow. Extensive preparations were made for the Faculty of Nursing and Midwifery 37th Annual International Research Education Conference and Honorary Conferring, which were due to take place on the 28th of February and the 1st of March 2018. However, due to a severe weather event, the conference had to be cancelled in the interest of health and safety for all. All events in the college scheduled to take place around this time had to be cancelled as a result of the extreme weather conditions. We have many eminent and renowned speakers today, including Ms. Noreen Keane, Strategic Project Manager and Capacity Planner, Mater Misericordiae University Hospital, Dublin; Mr. Enda Kelly, National Operational Nurse Manager, Irish Prison Service; Professor Rory Farrelly, Chief Director of Nursing and Midwifery, Royal College of Surgeons in Ireland Hospitals, Dublin; Ms. Grace Reedy and Ms. Mary Fitzgerald, Senior Process Improvement Advisor and Nurse and Assistant Director of Nursing for the Theatre Quality Improvement Programme, University Hospital, Kerry; Mary Deary, Age Friendly Coordinator, Louth County Council, County Louth, Ireland. Mary is responsible for the delivery of the Healthy Ireland programme and the delivery of the Healthy Ireland for Louth plan. Healthy Ireland Council is a multi-stakeholder national forum which provides the platform to connect and mobilise communities, families and individuals into a national movement with one aim: supporting everyone to enjoy the best possible health and well-being. A panel discussion will take place at approximately 15:40 hours, chaired by Professor Thomas Carnes, Interim Chief Executive Officer, International Council of Nurses, Geneva, Switzerland. And the closing address will be given by Ms. Catherine Clune-Mulvaney, Acting Executive Director, Faculty of Nursing and Midwifery, Royal College of Surgeons in Ireland. There will be a break for refreshments at 14:35 hours, which will afford us an opportunity to network with colleagues. The Royal College of Surgeons in Ireland is ranked among the top 250 or the top 2% of universities worldwide in the Times Higher Education World University Rankings for 2018, and its research is ranked first in Ireland for citations. It is an international not-for-profit health sciences institution with its headquarters in Dublin, focused on education and research to drive improvements in human health worldwide. Ladies and gentlemen, I wish you a very enjoyable masterclass and thank you all for coming to this event. Some housekeeping rules before we start. Please turn off all mobile phones and please take note of the nearest fire exits. Thank you. It gives me great pleasure to welcome Ms. Noreen Keane, Strategic Project Manager and Capacity Planner from the Mater Misericordiae University Hospital, Dublin, who will speak on digitalising the patient flow process. Please give a warm welcome to Noreen. Thank you.
Just a very special thank you to Ms. Mary Jacob, the Dean, and also to Dr. Dubner Frawley and all members of the conference and the committees for the kind invitation today, and including Catherine Clune-Mulvaney, Acting CEO. Just to bear with me for a minute, this is a log on to the hospital system, so we're keeping our fingers crossed that it will actually work, and it's a two-part presentation for you. So I'm just going to log on to a flow system. It's fictitious and it has been set up for the purpose of today. To show you how we have digitalised the patient flow system. It was introduced in 2014 within the hospital. So what I'm going to do is bring you briefly through the journey of a patient in the emergency department right into the bed when they occupy the bed, and supporting that to discharge readiness and actual discharge. So if that's in order with you, I will proceed. So hopefully we keep our fingers crossed with the firewalls and that everything will work. So this is a training system that we have in the hospital. And initially, we use this quite a lot. Now we do it more. And in the PowerPoint presentation, then I will give you the background and the context of the system. So basically, I'm showing you today, and we wish this was actually true, there are 5 patients, we'll say, in the emergency department here. The emergency department can look in. This is called the ED tracker. And again, I'm kind of briefly going through it. If I speak very fastly, too fast, just slow me down. This tells me then that this patient has been allocated to Our Lady's ward, but there actually is no time in. The benefit of this is we're allowing the wards managers and the staff at ward level to say the time the bed is ready and also when the patient is actually going to come up, and I'll go into that in more detail as I proceed. So this is the ED tracker. It's a screen, it's a standalone. Primarily this system is an inpatient system, so it covers the patients in the hospital, in the wards, and wards that we have off-site, which are in Fairview, etc. So this tells you that this patient has been allocated, but the bed is not ready for some reason. There's a patient in it and it's actually occupied, and these 2 patients have been allocated. And again, I stress that these are fictitious patients. This bed is going to be ready at 3 o'clock in St. Vincent's ward. So the staff there have said that the time that it's actually going to be ready, and and Our Ladies have said that this bed is going to be ready at 3 o'clock today. So what I'm actually going to do then is bring you back to the home button. And within that, this is where the whole system, and this is as it is in the live system within the hospital. We have a patient flow system here, and certain people have access to this. So I'm just going to bring you into the emergency department where the 5 patients are. So the people in patient flow or the site managers, these are the people who allocate all the unscheduled care as well as the scheduled care patients. So what we're actually going to do here, I'm going to take, as you can see, the name is quite fictitious, Mr. Pat Pink, and he's for admission. So I'm going to say that I am the person in charge of patient flow, or I'm the person allocating today for this area, and I'm going to say that this patient is going to go to Our Lady's ward. So the patient flow staff member will click on the patient, they will click on Our Lady's ward, and they will actually allocate the patient into one of the beds. So I'm actually going to say I'm going to allocate this patient into 11.3, and it's asking me, okay. So now this is visual, everybody can actually see it. So if I go back at this stage now and go into the ward, and I can look in at Our Ladies, so everybody sees it at this moment in time. So it's telling the story in the emergency department, it's telling the story to the patient flow, and it's telling the full story as it is to that Mr. Pink, Pat Pink is now allocated to Our Lady's ward. Now we can actually see here that it's flashing, so it tells us TCI means that the patient is due to come in. So basically each ward and each bed is set up as a bed card. So this is a patient, George Smith, under Miss Brannigan, and again it shows you the date of birth, it shows you the age the person is, and it tells you the amount of days that they're in the hospital. Again, I stress that this is actually fictitious. How do you identify? Because as you know, in our Irish system we have public and private mix. So we have here that this tells you that these are semi-private patients in the capacity that was before we had the change in legislation, and this tells you that somebody is in a public capacity, and also there's a figure or there would tell you that somebody is a private patient. So this is telling you that there are 27 beds and the capacity of the ward is 24. Some of the wards down here, we have actually 99 beds, 99. It's just today we can't show it to you, just the full ward, and this is due to the nature of the firewalls. So you can just take this, that it's actually a 31-bedded ward, and then there are extra beds that if the patient is leaving the ward, they're gone to the operating theatre, etc., that you will actually move them into. So it's telling you today that there are 3 patients with a predicted date of discharge to go home today on this ward, and there's 3 to come in. So hopefully we will get the balance quite quickly early in the afternoon. So we can see here, these are our 3 vacant beds. So we have bed 11.3, we have 12.1, and we actually have 1.2. So again, these I just set up a couple of days ago just to give you the overview of it. So the red on the top means the patients are coming from the emergency department, and if it's white on top, it's a transfer in from another ward or from intensive care, critical care, etc. What I should have said at the outside, St. Vincent's is the other hospital that has this. They have brought it in 2017, the same system. So at this stage then, I actually want to put the patient into the bed. So I'm going to acknowledge this patient, and the rule within the hospital is that if the nurse or the staff or the admin staff or the healthcare assistant do not acknowledge yes and confirm we're taking this patient within 30 minutes, the patient will be sent from the emergency department. So all the support has been given to the wards at ward level so that they can say the bed is ready, or if not, why it's not, and also to put in the time, and I'm going to bring you through that. So now we can see here that I'm going to acknowledge this patient that they're actually coming in, and I'm going to select the bed that this patient is going into. So as the patient flow manager, I had said that this patient is going into a level 3, but for some reason I might want to change it that this patient goes into 12-1, etc. So I can, at ward level, say for a change, for a reason, for all the multi-factors that it needs isolation, etc., it may be more appropriate that this patient goes into 12-1. So at ward level, I update it. Now, all this information is going back to patient flow simultaneously and also to the emergency department. And I have acknowledged this patient. I have now changed the bed. But I also want to say what time this bed is ready. So I'm going to set it now and say that the bed is ready now and that this patient can actually leave. And sorry, Murphy's Law, we've just cut out for a minute. So I have now at ward level said that when the bed is ready, I have said I can change the bed that patient flow have allocated to because maybe a different patient has gone home before the other. So I'm going to update reservation and press OK and press close it. So if I go back now to home and look at my ED tracker, it gives all the information here that's actually happening at the moment. So you can see now that Pat Pink has a bed in Our Ladies and the bed is ready from 13:49. So that patient should be leaving the emergency department now. There's no delay, no more phone calls, nothing that actually happens. So it's actually telling the full story. So now I'm going to go back to Our Ladies and I'm going to take it that this patient has arrived on the ward, and I'm just watching my time there as well. And I'm going to put the patient into the bed. So on average, the Mater would have probably about 18,000 admissions in the year. So that you can imagine that's double the amount of phone calls that have been reduced immediately. So I'm going to select admit. I didn't want to put it into that bed, so I'm actually not going to do it. So I'm going to deselect the admit and I'm going to put it in this patient into 12-1. So I select Mr. Pat and it asks me, do I want to put him in? So once the patient arrives in the ward, the patient is actually placed in the bed. The nurse then continues with their assessment and comes back and starts updating it. So I'm going to start updating it quite quickly and just give you a quick overview. There's quite a lot of information here on the left, there's quite a lot on the right, and there's a lot of information here. So if you take it now, the first part is the patient coming in. All within the ward is the actual inpatient component of the patient care, and all of this is actually when they're exiting or leaving the ward for one reason or another. So this is a patient come in under a gastroenterologist, the date, etc. They're now 1 day within the hospital, today's date, and you can see quite a lot of information there at a glance. This is used, of course, for the handover. So I'm going to say now this is a patient who needs the occupational therapist, they need the social worker, they need the speech and language therapist. Now, this, unfortunately, is not connected to the order comms yet for the hospital, but alerts everybody, look, at the point of entry, we need to start moving and getting all of this involved immediately. If the patient had an infection, and again, it's the high-level infection, we can actually highlight that. The mode of transport is one of the key areas because, again, we're trying to reduce and minimise the diagnostic departments so they can actually look in. It's in at every computer terminal in an office. They can look in to see how will the patient travel. The majority of patients, of course, you want them to walk, etc. Feeding indicators if the patient needs assistance, and we have green trays to identify that the patient needs assistance. So the healthcare assistants, staff can say this patient needs assistance with their feeding. Again, I know I'm going very quickly, but this is to give you the concept. It's not something that you're going to remember. So we can actually say, if I was speaking here and somebody we didn't want to know about Mr. Pink Pat and the relatives are close by or whatever, we can do that. The patients on telemetry, so if they're on the cardiac ward and they're under a physician, we know that, well, you can. That's why they're actually there. If they have a history of dementia, the rule of thumb is you don't put it in unless it's written on the health record. You don't surmise it in case it's delirium or any of those. Falls risk is there, and each patient is on the register of IV fluids, cannula, major trauma. As you know, many of you will be familiar with the TARN project. So if we get a lot of patients with trauma, if the patient's on oxygen, it's important that they know when they're being transferred from one department to the other for tests, etc. We are looking at medicine reconciliation, etc. And there's quite a longer list there, but won't go into those in detail. So then going across, there's other infection control areas that you can look in here and see if the patient had an outbreak of infection, gastroenteritis, God forbid, or something like that, who's in the 6-bedded, and if there's associated infection. So there's a quick track there if somebody's infection. In here, if you're writing your public health nurse letter, you can quickly get the demographic details. Again, this is very fictitious where the patient is, etc. So now the key thing is I just want to take from this patient, and we're saying about Mr. Pink Pat, I'm going to say he's in the radiology department, press OK. and press OK. So this is where it's going to ask me just to update all of these. I'm going to say, sadly, this patient is MRSA, etc. So everybody can see. So you can do it all together. You can update it all once the nurse has done their assessment, and this gives a full picture. So now this sign in the background means that this patient is in the radiology department. So if I check it, you can actually see then this patient went to the radiology department and who took it. That would be by the portering staff or the healthcare assistant, and everybody gets their title. So if it's nurse, it's RN. If it's CNM, it's CNM. If it's the porter, it's porter. Noreen Keane took the patient to the department. So everybody can track it. And the important thing with that is if a patient is going from one department to another, so they're going from radiology to cardiovascular lab, people can look in, and the phone calls are don't need to be exchanged, and the patient can transfer without coming back to the main ward, because we know patients get multiple calls for the different diagnostic departments, etc. So that's giving it to you as an overview, and then I'm going to briefly go through the discharge planning situation, which is quite good. We want to put in the predicted date of discharge, and this is the biggest debate that's in Ireland at the moment, who's the responsibility to put in the predicted date of discharge, and it's mixed and it's varied, and again we've gone back to high levels and HSE, Department of Health, etc., and it's going around. So for the purpose of today, I'm going to say this is the patient. We expect them to be in, even though we've already said that they're major trauma. And we're going to say, okay, well, first of all, I'll actually put in today's date just to bring you through it correctly. So we're going to say this patient is actually a confirmed discharge today. So what does anybody want to see in patient flow or in the department is that it's all green, and many of your patients are being discharged to support the patients coming in from the emergency department. And again, there's hubs and huddles and all of that I won't go into, which actually support the movement of all of this at different times of the day. Then we'll say the patient is a potential discharge, and within that we can actually say why, when and why the patient is a potential discharge. So this patient is going home, they have to have a read blood test. Now we only put that in the last 48 hours because there's no point if the patient's care is going to be longer than 48 hours doing quite a lot of this work. So the patient is waiting a blood test, they're waiting for a PET scan, to check this. They also, we can actually put in if there's an outstanding consult, the Murphy's Law, just as the patient is about to go, there's something else is requested. That has come to light. So again, you can put in the request, who they're waiting for, as in all the teams. So we'll say this patient is waiting for the bloods and the CT, and if they're actually done, then they're actually removed, vice versa. They can be waiting for quite a lot of items in the community, transport, etc. I won't go into them in great detail. They can actually be waiting for their results, etc., or consult. So there's a whole list there, and the most common ones are on the higher of the list. So we can say this patient is a potential to go home today, and we will say that they are actually waiting OT and physio to be arranged in the community or wherever that actually is. And again, you can scroll up and down, or they're waiting for the blood test results. And if I press OK there, you can actually see, sorry, it didn't save for me for some reason. Sorry. I'll just select one of them. If we say that they're waiting blood tests, I can't get down to the close button, unfortunately, but it would actually start counting numbers here. So if this patient was waiting 5 items, you would actually see it here in line with the yellow triangle that's already there. Unfortunately, the screen just isn't big enough to map it across for today. So now we're saying that this patient is a potential to go home today, provided the blood tests are within the normal range, etc. Also, we can put in the destination, which is quite good. I can't close that, so hopefully it won't clash. So we can say the patients are going back to the hospital that they were actually referred from, and I see people from Beaumont here, but that's one of the hospitals that our patients go to mostly, that they return, or Connolly Hospital. If they need to go in the community, of course we know that over 80% of the patients will go home, and they'll go home on their own, or they could go home with family members, they could be, for a while, etc. So all of this information is here. And why is it so important that we actually put it in at that point? We can look at it quickly and we can see that the whole build-up is here. So Noreen's going to go home on her own, but initially she may have to go with family members. And again, the list is endless, that you can build it up from rehab to lower level rehab to home, etc. So you're actually giving the full message. So that's briefly bringing you to the patient, and they're there. Now we're coming to the stage that they're for discharge, and I can do a direct transfer, that they go to our patient transfer unit. And again, like seeing those patients there in Our Ladies, you can actually see it'll be a green arrow. Or I could change it and say, no, they're actually going to another ward. This patient is going to be changed under a different consultant and go to a ward, and pick another ward. We'll say they're going to go to the orthopaedic ward, and press OK. So once I do all of that, that information goes immediately to patient flow. So they now have a whole list of who need to go to the right ward, getting the right patient in the right ward at the right time. So again, that's giving you an overview. So I've kind of really brought you to the discharge readiness, and now we're going into the destinations for the patients. There's other areas then we can say that I actually didn't put in. If there were potential, we can say this patient is going home in 4 days, and again, or 3 days, and again it's changed accordingly. So if this patient is going home on Friday, we look at it and we can say this patient is going in 3 days. So again, this is where you concentrate your efforts to get the patients home much quicker, that are closer to discharge. And unfortunately, we sometimes have occasions where patients are delayed for one reason or another. We can press OK, and in here are the high level HSE reasons why the patient can't go home. Majority of patients, maybe home care package, etc., has to be supported with them. After 48 hours, if this hasn't happened, it actually vibrates, so that actually alerts you to go back and check, is it still a home care package, or has the patient's condition not improved or improved, that they can actually transfer to another area. And then finally, I'm going to bring you, this poor patient has been brought through the system very, very quickly. I'm going to discharge the patient because we're very fortunate today that a bed has come in a nursing home or in some area in the community or whatever is required. And again, we have it here that they go maybe another area, specific area of accommodation or whichever. So that's why we would take other, not going home on my own or with my family, and I press confirm. And as soon as I press, and again, the key is that we want to improve our metrics in relation to this, that we're discharging on real time. And if I select discharge and we say that this patient is actually going home, or they're going to another area, and again, we're updating quite a lot of this information. It's more updated on the live system. So I will just say that this patient is going to the nursing home and press OK. And sadly, this patient has now left the ward. And that's it. Okay, I'm sorry now, I'm going to have to get the support from the staff here just to give you, just to open a PowerPoint presentation. And I'm going to take this laptop away. If anybody wants to ask a question. The system came from a company called Aura, which has since been taken over by Servlec, and then they have been now taken over by November. And that's not a good idea, that a lot of the system or change is too quick. I think the biggest problem for us that we had to marry it into the Irish setting because it was an English system and it was set up more for psychiatry and paediatrics than the acute general setting. But it was the closest that integrated with the software that the hospital already have. And unfortunately, we don't have some of the big systems that are in a lot of the HSE hospitals, like Cerner, etc., etc. We actually had a standalone unit, and that was a disadvantage. So if anybody is thinking of a system and getting some software, there are problems with it. And I'll briefly bring you to this time in order. Okay. 5, yeah, I'll be quick through it. It's the short one, yeah. Okay. Okay, so briefly I've just brought you through the journey, and again I'm just going to contextualise it. Why did this all happen? Again, it's due to the performance challenges that we had out there to improve the service, give it quality, have it at a glance, and that we wanted to reduce cost, etc. So there was a lot of lean projects done at the time in relation to, you can see quite a lot of them here over on the right hand side, telephone calls, etc., what had happened. So what we want to do is reduce the non-value add surrounding communication, get it better focused, as I told you, reduce all the phone calls, as I mentioned earlier, get the right patient to the right bed. I think the benefit of the project initially was that we were standardising it, so every whiteboard was the same. It wasn't different on the wards, on the wall. The aim is to have it at real time, and I'll confirm that shortly. And I suppose the key thing is to engage with all the stakeholders and the users, and it's improving, but it's slow. It's a slow process, and we all know that on healthcare. I suppose the key thing that the focus is that we want to stop those interruptions that I've mentioned to you on the Lean project, and get the staff into direct patient care and reduce those interruptions, because the staff nurse or the CNM is interrupted about 5 the conversations can be less than 5 minutes, and actually anything between 30 to 50% of their workload in the day can be interruptions, asking where patients are, where they're going with relative staff, etc. It has provided good support to the staff, and our biggest challenge is if something isn't working for some reason or whatever, it's a problem. I suppose the one thing I should say to you is that it's internet dependent, which is not probably one of the best, but it's a link to it. Here, the two systems are interlinked. Most of the information, of course, will be on our PAS system, which we call Patient Centre, and this is the screen, but one speaks to the other. So if I'm on the ward, I just swipe in with my hospital identity, and that gets me into the system. Everything is logged and recorded. It's at the point of every terminal and computer. So if the physiotherapist goes up, all the computers, the 6 computers on the ward are in use, they can go back to their own area, or they can come back in the morning, they can look and see where their patient is on the ward. The good thing is we can do a lot of auditing and registering, see who's updating it, and it's person dependent. That's right across CNMs, RNs, but that's across all the professions. I suppose the key stakeholders, if any of you were implementing it or thinking about it, there's quite a lot of people, as well as the company that you get it from. There's all your own steering groups, which was a lot of work in initially, because we had to Irish it, turn it into the Irish setting to suit us. And don't forget your electricians and carpenters, because every screen had to be applied, every computer, your IMS department, etc. It was a lot of work, but we did it over less than 6 months, with Christmas and Easter intervening in 2014. The training programme, it can be labour intensive and demanding initially, but it settles after that. And we've actually brought it into induction, and we have a special training room which supports a lot of the interns and the big groups that you might have at one stage. And again, we did it right across the spectrum. Nursing and medical staff would have the greatest access. Health and social care would have a limited access, but a certain amount, almost the same. And then we did it with portering staff, we did it with ward clerks and the healthcare assistants. The bidirectional flow, and what does it actually do? The flow is good, it can be done in seconds, it can link off-site, etc., etc. Sorry, this is running a race of its own today. And then you have the graphical view, and I've mentioned a lot of the others areas in it. Sorry. And the key thing is that it supports us with clinical alerts and also quality improvements, because you can see I can close a bed there and say that patient is in that isolation room for whatever reasons. And again, I skipped through quite a lot of that. So that's why we have a lot of alerts inbuilt into it. So the patient flow staff don't have to say, well, can I, what category is the patient in? Maybe they may be a palliative patient, etc., etc. So all that communication is minimised and not repeated day in, day out, etc. So that's where it supports the quality improvement initiatives that we're trying to and working towards complying. And again, there's another area with it which is a separate link to note. I'm not going to go into it in great detail, but it actually gives you quite a lot of more information that you can look into. Now, we haven't given this to everybody yet. It's slow. From the point of view is you need a lot more computers on wheels, access, etc., etc. And we're also wondering at the benefit. We can have the navigation hub through it, but it's very good for standalone areas. We'll say the nurse, health and safety nurse, etc., can look at all the bariatric patients with the dietitians. They can discuss all that at the nutritional forum. So we know on average now all the time how many bariatric patients we have, because there's an S sign that we put, and S means safeguarding, etc. I didn't go into all of that detail, but again, you can look at it here. This is the S that I'm talking about. So if we check with the, just because it's PowerPoint, it won't show up. I'm nearly thinking I'm on the live system. So we can see, if we look at a ward like this, we can see that this patient has gone to the operating theatre. The patients are actually coming in. We can see here, sadly, somebody has died. So that stops the staff from ED phoning all the time. Is the bed ready? Is the bed ready? Is the bed ready? We know we have to acknowledge the sadness that surrounds it, and with the family. There's also ways that you can highlight if they're waiting for urgent tests, etc., etc. We did try it a couple of times, but it didn't give us as much support as a direct email going to all the diagnostics, which was something we had in place. So we kind of haven't worked with that. I suppose briefly, and the one question I know a lot of people will ask is, what does it not do? It doesn't replace our IMS, our health records, or our communication and reporting systems, or discharge summaries, etc. So in brief, and to summarise and to conclude, so we're at the moment, we're continuously updating, upgrading, adding. It's a disadvantage that we're more or less standalone, because we're at different levels to the other hospital. We're adding new icons again to support rehabilitation and all the national programmes that are there. We're actually trying to work in line with the Disability Act of, identifying people with the sign for the eye and the ear. So we have those being developed at the moment. We're also looking at the pharmacy that I said to you about, the medicine reconciliation, and that they say yes, medicines are reconciled, so the patient can go and be discharged much earlier, or go to the patient transfer unit. I suppose the one thing I will stress in conclusion then, that it's not just about the system. Everybody can do it equally as good with their own whiteboards, etc., etc. It is really the whole process of re-engineering about it, and it's not going to give you all the KPIs or the improvements that you want. You have to work with a lot of other processes in line to keep that. And again, I have to say, the one thing is that I do want to stress to you is that it shouldn't be person related. Thank you. Sorry. I'm just trying to close it down, or maybe I'll leave it to the experts. Thanks to everybody. Thank you.